So this is a combination of two targets. It's a very small molecule which has on one part a CD3, and this CD3 part attracts T cells which are in the body, so the normal immune system. On the other side, the B-specific antibody has a CD19 part, and this CD19 attaches to the target cell. The target cell is the leukemia cell which has CD19 on the surface. So this B-specific antibody brings the T cells very close to the target cell, and this activates actually the T cell, and the T cell proliferates and kills the target cell. No, because they don't identify the target cell, but by the B-specific antibody they are brought directly to the target cell. And then they can even detach after killing one cell and then seek for the next target cell and kill it. So
right.
It's a serial kill, even very effective. With very small concentration of the molecule can kill a large amount of leukemia cells.
So that means limiting the toxicity to the rest of the patient?
The toxicity depends also on the activation of the T cell, of course, because they release cytokines, for example, and this contributes to the toxicity. It's part of this treatment. So these were patients with relapse of refractory disease. This means they had first a response to the chemotherapy and then relapsed. And we selected specifically a poor subgroup, meaning patients with early relapse within 12 months of first remission. This was one major group. Then refractory relapses, patients who had a salvage treatment and didn't respond. Relapse after stem cell transplantation, which is also a very unfavorable group, and patients with primary refractory disease. These are patients who never responded to any standard therapy. So they usually get again a combination chemotherapy, and the response rate for this type of patients is around 30%. So the response rate was overall, with this approach, 43% complete remissions, and this is quite a good proportion in such an unfavorable patient population. And in addition, not only the complete remission measured by microscopy was seen, but in these CR patients, 80% had a molecular remission, meaning that they had less than 0.01% blast cells in the bone marrow. Now, first of all, such trials have the aim to show that a new compound has an anti-leukemic efficacy. So this has to be shown also for registration purposes of the drug, of course. Then the patient, if the patient has a CR, the patient has a chance to get a stem cell transplantation. And this is a major method to achieve a cure in these patients. So they have a CR with this new compound, then get a transplant, and then the patient has a chance to be cured. This is, for the moment, the situation which we can do with this drug. In the future, of course, there are other options. No, it depends all on the CR rate. So the CR rate, the CR offers a chance to have the transplant. So since we had 43% CR, it is a higher chance to get a transplant than with a standard therapy. But there are many other factors confounding, of course, the chance of a transplantation. So it's difficult to make a guess, because the transplantation depends on whether they have a donor, whether the healthcare system pays the transplant. So there are many factors. It's not an issue of the drug. It's more a general issue. So the drug gives you the opportunity to just offer the patient the transplantation. Absolutely. So this is a single drug, and I think the result is very good. If you look for history, other drugs registered for ALL like nelarabine or clofarabine, they had single drug activity of 20% CR rate. So we have to keep in mind this is a poor population, and I think absolutely that we can use this drug at a better situations even in the future. For example, in low-level disease like minimal residual disease status, or even in the first-line treatment. So first of all, we know now that this drug is effective, and we have learned a lot also about tolerability. And it gives an opportunity to integrate this compound, which has a totally different mechanism of action compared to chemotherapy, in the future first-line management of ALL. So this is a big hope, that we have not only chemotherapy but different approaches to treat these patients. And for example, to reduce the number of resistant development in these patients. Mainly the major toxicities are related to these cytokines, like fever, the typical sign, or headache. The patients also show a drop in peripheral blood count. They show an increase of CRP, for example, so all kind of inflammatory signs which are related to cytokines. And there's another type of toxicity, which is a cerebral toxicity, CNS toxicity, like encephalopathy or seizures. That can occur also in part of the patient. Has been observed in the past for other T-cell based therapies. Yeah, the important thing is here that we have a really proof of principle in a very large number of patients that the T-cell targeted therapy can be effective in a very aggressive subset of acute leukemia, and this is a very interesting result, and hopefully can be expanded in the future also to other disease entities and to other situations in ALL patients.